So now that we know, guys, about all the types of our acquired cataract, there is cataract, there is loss of vision, so it will have to be treated. So now we move on to the treatment of cataract. So my first question, which I've actually already answered, if you remember, what is the treatment of cataract? Is there any medicine which can treat cataract? Is there anything which can treat cataract, which can reverse cataract? I'm giving you a clue. No. So I told you there is nothing which can treat cataract. At last, we have to do a surgery. So the only treatment option is surgical. So that's what we are discussing, the surgical treatment options for cataract. So the names of the surgeries. Let's start with the oldest surgery, number 1. The oldest surgery which was done was ICCE. I am saying which was done. Please hear carefully. What is the full form of ICCE? Intracapsular cataract extraction. ICCE. In this surgery, what was done, if I basically tell you that the whole lens along with capsule removed. Okay, this was what was done in the surgery, but this is not done now. The only indication I can say is in cases of subluxation of lens due to greater than 180 degree of zonular dehiscence. Zonular means the ciliary zonules. What suspends the lens in the center, everybody? The zonules. So if greater than 180 degree of the zonules have broken out, so basically your lens is tilting, subluxating, that is the only indication for ICCE. Even though it is the only indication, yet there are other things that you can actually do. So you don't end up doing ICCE in these cases also. But if you're talking about the indication, this is the only indication, right? Now, ICCE is not done. So I'm just putting a cross so that you remember. What is done these days is ECCE technique based surgeries. What are we trying to say? What is ECCE? What is the difference between ICCE and ECCE? Only a single letter, guys. Instead of intracapsular cataract extraction, it becomes extracapsular cataract extraction. Yes or no? So extracapsular cataract extraction, that means we are not extracting the capsule. So the difference, if you understand, is whole lens removed except the capsule. So in all the surgeries that are done today, we are basically just modifying the base ECCE technique and using them. So all the names of the surgeries that we are going to discuss from now on are ECCE techniques. They are removing the lens but not removing the capsule of the lens. Understood? So what is the name of the surgery? 2A. Conventional ECCE. Conventional ECCE is the point where ECCE started. Then came the surgery SICS. What is the full form of SICS, guys? Small, yes, very good, incision cataract surgery. Okay. After SICS came, yes, phaco. Hey, what is phaco? Now tell the whole name, na. Phaco emulsification. Don't get into the habit of shortcuts here. Phaco emulsification. Okay. Now, all these three surgeries are ECCE techniques. The difference is in the site of incision and the size of incision. Okay. Now, What do I mean to say by the site of incision or the size of incision? See, we all know that lens is an intraocular structure. Very crudely talking about the cataract surgery, what do we do in cataract surgery? We make a cut, we go inside. Cut means incision. Yes, we make an incision, we go inside. We remove the lens and we implant an artificial lens, which we call as IUL or intraocular lens. Yes. So basically, because your lens is an intraocular structure, you need to go inside. To go inside, you have to give an incision. Now, where would you give an incision? It's just like entering your home. When you have to enter your home, the first gate you have to open is the outermost door. Yes. So that means to get inside the eye, you have to make an incision in the outermost layer. So what are the three parts of the outermost layer? See, understand, you know the question now and you know the options also. So there can be only three options for the site of incision. It can be either cornea, it can be sclera, or it can be limbus, the three parts of the outermost layer. Yes. So what is the site of incision in conventional ECCE? It is at the limbus. The size of incision is 8 to 10 mm. Why is it 8 to 10 mm? Why is it 8 to 10 mm? Basics of lens, everybody. Because the equatorial diameter is around 10 to 10.5 mm. We know that. Yes. SICS, the site of incision became a sclera and the size of incision reduced 5 to 7 mm. Then phacoemulsification. The site of incision is now cornea and the size of incision can vary from 2.2 to 3.2 mm. Okay, everybody? I hope there is no confusion in this. Now, a lot of students say that there is a new surgery which is known as MICS, micro incision cataract surgery. But this is not a new surgery. This is not a modification of the technique. This is nothing. In micro incision cataract surgery is phacoemulsification, but with an incision size of 1.8 mm or lesser than that. That's all. Only the size of incision, because of the instrumentation, the advanced technology, we are able to have a smaller incision size. It is not anything else, no other difference. So for me, phacoemulsification is equal to MICS, just the size of incision has become smaller. Now, if you see with advancement, everybody, the basic thing that we are trying to achieve is reducing the size of incision. Why? Because the smaller the size of incision, the greater or the quicker the healing, the lesser the chances of post-operative infection. Everybody, I hope you understand this. Yes? Now, let us complete the list. After phacoemulsification, if I ask you, what is the latest cataract surgery? Now it is now 5-7 years old, but still it is the latest cataract surgery. So what is the latest cataract surgery, everybody? Yes, a lot of us know the name now, everybody. FLACS or flax, I can say. What is the full form of FLACS? The full form is femtosecond laser assisted cataract surgery. Femtosecond laser assisted cataract surgery. So if you understand, the main word important here is the F, the femtosecond part, okay? And the word L, laser. This is the first surgery where we have used the word laser in cataract, everybody. Yes. So this is the laser based surgery, femtosecond laser assisted cataract surgery. Now, my problem with students starts at the word laser. Why? Because I've seen that a lot of students, when they don't know the answer to a question, they resort to the word laser. What is the treatment of this? Laser. What is laser? Laser is nothing but an acronym, guys. LASER, light amplified stimulated emission of radiation. What is laser? A lot of the teachers, the faculties, they use laser in the class, yes, to point something on the board. Does that mean if by mistake they turn the laser and it goes into your eye, your cataract surgery will be done? I hope you understand what I'm trying to say. Yes. So when we are talking about a laser, laser is just a generic name, everybody. We need to know the details. Which element is producing the laser? Is it an argon laser? It is a fluoride laser? Is it a helium laser? Is it a neon laser? Is it a CO2 laser? There are lots of lasers. Yes. So when we say laser, we should know the laser. So the laser here is produced by neodymium glass. Not YAG, guys, not YAG. I know you know ND arc, but it is not ND arc. This is ND glass. Okay. So the name of the laser is ND glass. Now, whenever we are reading about a laser, we need to know at least two things. What is the wavelength of the laser? The wavelength of the laser is 1053 nanometers. Secondly, what is the mechanism of action of this laser? Now, what do we mean by mechanism of action? So see, laser is, as we said, radiation. It is a beam of energy. So when we are using that beam of energy, it is producing some change in my eye. Yes, that is leading to the treatment. So what kind of changes can it produce? Think about it. Energy. Energy can heat something. When it heats something, it is burning. Okay. So I can say the mechanisms can be, at the corner I am writing, mechanisms can be burning. When we burn, we call it photoablation. Okay, everybody? Or instead of burning, if the energy is higher, everybody, it can break a structure. Yes? So breaking is called as photo disruption. Or everybody, we can have coagulation. Okay? So I remember it as BBC. Burn, break or coagulate. Ablate, disrupt or coagulate. Am I clear to everybody? Ablate, disrupt or coagulate. Either you burn, ablation, you break, disruption, or you coagulate. Now using your common sense, can you tell me in cataract surgery what our laser must be doing? Are we trying to burn the lens? Are we trying to coagulate the lens, or are we trying to break the lens? Think about it. The incision size is very small, maybe 2.2 mm, maybe 1.8 mm. The diameter of the lens was 9.5 to 10.5 mm. How can you take out such a big structure from such a small incision? You must be doing what, everybody? Yes, you must be breaking the lens into small pieces to take it out. So the mechanism of action of this laser has to be photo disruption. Yes, I hope you understand the basics. Yes. Now, when I heard the name of the surgery FLACS, I thought femtosecond is the name of the laser. But the name of the laser we have studied is just now ND glass. So what is femtosecond, everybody? Femtosecond, yes, is a unit of time. Unit of time. So each laser shot is fired only for a duration of 10 to the power minus 15 seconds. Nanosecond minus 9, picosecond minus 12, femtosecond minus 15. So the duration of each shot of laser is only 10 to the power minus 15. So what it does, everybody, because of such a small duration, so what is the use of such a lesser duration of energy, everybody? The collateral damage to the surrounding tissues due to dissipation of energy is reduced to the maximum effect. So there is no collateral damage to the surrounding tissue. Yes, I hope you understand the name of the surgery, FLACS, and all the questions that can be asked as far as the word laser is concerned. These are all the names of the surgeries. Now, the most commonly done surgeries these days is phacoemulsification. Yes, the best results are of phacoemulsification. So what we'll be doing now are discussing the steps of phacoemulsification. Steps of phacoemulsification. Before we move on to the actual surgery, everybody, there has to be some pre-operative precautions, pre-operative preparation of the patient. Yes. So what are the pre-operative steps we can say? I hope you understand, when I have to take out lens, if my pupil is constricted, the area of view is very small. The area of surgery is small. So I need to dilate the pupil first of all. So the first thing pre-operatively, as a pre-operative part of preparation we need to do is, we need to dilate the pupil. Now, the dilatation of your pupil can be done through any mydriatic cycloplegic drug. Usually, what is used is a combination of tropicamide and phenylephrine. Or cyclopentolate. Because we do not need a very lengthy duration of mydriasis, everybody. That is why we focus on the short acting mydriatics. Okay. The second thing you need to do is, obviously we are doing a surgery, so there will be pain. So what do you need to do? You need to do anesthesia, local anesthesia. Now, this anesthesia can be given in various forms. It can be topical anesthesia. It can be a peribulbar anesthesia, or it can be a retrobulbar anesthesia. Okay. In crude language, we explain to the patient that if you are getting a topical done, there is no injection in your eye. But if you are getting a peribulbar or retrobulbar injection, we are injecting. So there will be an injection in your eye. Okay. If you don't know the names, the meanings of these names, please go to anatomy videos, everybody, where we have discussed in detail the routes of drug administration. Now, my question to you, leave alone topical. Out of peribulbar or retrobulbar, which mode of administration is preferred? Yes, the answer is peribulbar. But these days we see that a lot of cases are being done under topical anesthesia. Almost all the surgeries usually are being done under topical anesthesia. So what do we use, everybody, as an anesthetic agent? We use bupivacaine, long acting, plus lignocaine, plus 1:2 lakh dilution of adrenaline, plus, for better and quicker penetration, hyaluronidase. So long acting, fast acting block. So this is what is used in peribulbar block or peribulbar anesthesia. If we are talking about topical anesthesia, usually what is used is proparacaine eye drops. Okay. Are we clear about this, everybody? I hope there is no confusion in this. And that's your second pre-operative preparation that you need to do, everybody, apart from dilatation, local anesthesia. Also, everybody, before surgery, we need to have asepsis. So, universal prophylaxis is the use of 5% povidone iodine, or at a lot of places we also use betadine solution. This has to be instilled into the conjunctival sac. Let it remain there for 30 seconds to 1 minute and then wash it off, everybody. Yes, so that the flora and fauna, any sepsis which may occur due to some organism on the surface is at least not a matter of concern for us, right? So these are all the pre-operative preparations. Now we move on to the steps, the operative steps of phacoemulsification. So now to have a better understanding of our intraoperative steps of everybody, first of all, let us see a video of the surgery to have a better visualization before we start writing the steps. So at the beginning of this video, let us first see a very important point, guys. We see that the whole pupil is dilated. Yes. Why is it dilated? As I've already explained, that to have a field of view, everybody, as well as a field of surgery, we want to take out the lens, everybody. Lens is behind the pupil. Now as the first step, you can see that an MVR blade, everybody, is creating an incision, clear corneal incision, right? And you will see that this surgeon prefers to create two side ports or side incisions. So he is creating another side port or side incision. That's our step one. It helps us to inject viscoelastic as we see. What is a viscoelastic, guys? See, there is aqueous in the anterior chamber. That is a fluid that will keep leaking out. So we need our anterior chamber to be stable. So to stabilize the anterior chamber, we have to fill it with a more dense material, and that material is viscoelastic. So it gives us a stable field of surgery. Now, after the anterior chamber is filled with viscoelastic, this surgeon tends to perform step 4 before step 2 and step 3. These are all surgeon preferences. You can see a 2.2 mm keratome being used. Yes, now see it, everybody. So the keratome is creating a biplanar incision. First it is going in the cornea, then it is going down to create an incision. Now this surgeon prefers to do step 2 and step 3 later on, but those steps are done through the side port. You will be able to see a 26 gauge bent needle creating a flap, everybody. You can see now, you can see a beautiful flap has been created in the anterior capsule. The anterior capsule has to be cut, everybody. Yes, to be able to touch or remove the nucleus and the cortex. So you see that the surgeon is creating a circular window, everybody. You will see he is completing. You can see the margin of the circle here, everybody. You can see the margin of the circle here, everybody. Now the surgeon is coming closely, and the surgeon is completing this step. This step is known as CCC, continuous curvilinear capsulorhexis, guys. Now the capsulorhexis has been complete. You will be able to see a complete round circle, everybody. See, everybody, you will be able to see a complete round circle going here, coming here, everybody. You are able to see a complete round circle. Now, this surgeon preference to do it without staining the anterior capsule. As we'll discuss in the theory, that some surgeons can stain this anterior capsule with a trypan blue dye. Through that, we are able to see a blue surface, and it becomes slightly easier to be able to perform this step. This surgeon is an experienced surgeon. He is able to perform this step against the red glow of the fundus. This orangish or reddish glow that you see, everybody, this is the fundal red reflex which is showing through. Now, you see we have taken a cannula and we have gone below the anterior capsule, injected fluid such that there is hydrodissection. Hydrodissection is what, everybody? Hydrodissection is separation of the cortex from the capsule. And that is why you will be able to see that now we are able to rotate or move the nucleus within the capsular bag or the capsule, everybody. Because now it is free from attachments of the capsule, and now I have free rotation of the nucleus. Now you will see, everybody, that the surgeon inserts a probe, a pen-like structure. See at the bottom of your screen, inside. This is called the phaco probe, everybody. Yes? Through this phaco probe, he will try to remove this nucleus. This phaco probe has three functions. The first, it can irrigate. See, when we are sucking in something out, we have to keep on replacing fluid, everybody. Irrigation. It can aspirate, it can suck, and it has energy. Phacoemulsification, ultrasound energy. You will see the ultrasound energy in action in a while, everybody. Let us see. See now. Now you see that the surgeon is using ultrasonic energy and is creating a groove, everybody. Can you see? It is looking as if there is a cake and I am eating that cake. Okay. What is this energy? Ultrasonic. But this ultrasonic energy basically does what? At the tip of the probe, it converts it into to and fro motions. So basically we are chiseling, everybody. Through chiseling, we eat up the material. Now you will see nuclear fragmentation. Everybody, let's see. The surgeon will soon be able to divide the nucleus into small pieces. Everybody, let's see. Yes. See, now you will be able to see a break. You saw a small break. Now you will be able to see a complete break. The surgeon again attempts to break the nucleus into small pieces. And at this point of time, yes, see, now you see a complete break, everybody. You see here a complete break has taken place. Now more such breaks are created. Another break has been created. Another break has been created. So more such breaks are created to form smaller nuclear fragments so that it becomes easier to suck them. We can't suck the whole nucleus together, everybody. So now you see that the broken pieces, again breaking pieces, and now the surgeon is sucking them in the phaco probe through the aspiration or the vacuum action, I can say. Small piece sucked in. Again you will see small piece sucked in, everybody. Yes? Keep on seeing this, everybody. So this is basically called phacoemulsification. The word phacoemulsification comes from here, that using the ultrasonic power, converting it into to and fro motion, we are doing emulsification. We are emulsifying the small fragments of the lens, and we are sucking all the lens particle through our phaco probe. Now you can see that almost all the nucleus has been removed. What remains here, everybody? You can see some cortical fibers in the periphery. You can see, everybody, some cortical fibers which have been loosened by hydrodissection, but they have not been completely removed. Now we take another instrument which looks like the phaco probe. Everybody, you will be able to see this instrument here. It looks like the phaco probe, but it is actually called the I&A. irrigation and aspiration. That means it is doing just two functions instead of three functions. It is irrigating, fluid obviously needs to be continuously replaced, and it is aspirating, it is sucking in these cortical fibers. Cortical fibers, if you remember, are soft always. Nucleus is hard. Nucleus is large and hard, so we need to break it and emulsify it. Cortex is small, so we can just suck it, everybody. Soft and small pieces, we can just aspirate or suck them. Now you will see that gradually all 360-degree, the surgeon will move the I and A, everybody, irrigation and aspiration, and will be able to suck all the cortical material. Now you can see going here, everybody, sucking in, coming here, sucking all the cortical fibers. You can see them peeling out easily because they have been hydrodissected. Had they been stuck, everybody, the posterior capsule would also have come in. Now that the cortical fibers have been cleaned up, everybody, you can better see against the red glow the margins of the anterior capsule. See, everybody, you can see a beautiful anterior capsule, capsulorhexis, everybody. See, continuous curvilinear capsulorhexis. Okay. Now you see that the surgeon is injecting the lens, IOL, through a small 2.2 mm incision, but the diameter of the lens is 6 mm. Why is it possible? Because this lens is foldable. You could see it was folded and now it is slowly unfolding, everybody. Yes, it is slowly unfolding, everybody. And now you will be able to see that the surgeon is pressing it down below the anterior capsule and rotating it, everybody, to see whether it has been completely able to get everybody inside the capsular bag. And once we are able to implant the IOL in the capsular bag, we say our surgery has gone to be successful. The only step which remains is the small incisions we had created, we want to close them, but we do not suture them, guys. We just close them by hydroclosure. So we hydrate those. So there is slight edema. Edema leads to closure because our incisions are small, 1 mm and 2.2 mm only. Now that we have seen the video and probably understood a little about the steps of the surgery, let us write them and solidify them in our memory. Okay. So, what was step 1, guys? In the first step, if you remember seeing in the video, we were making side port incision. Okay. Now, side port incision can be made using any of the two instruments, as I had explained. This is known as a 15-degree blade, and this instrument is known as an MVR blade. If you remember seeing in the video, the surgeon was creating the incisions through the MVR blade. Yes, this is called a 15-degree because you see with the 90 straight line, the angle of the blade is at 15 degrees, everybody. Okay. Now, through the side port incision, what do we do? Step number 2. Through the side port incision, we stain the anterior capsule of lens with trypan blue dye. As I had said during the video graph, it was the surgeon's preference that the surgeon was not using the trypan blue dye. A lot of surgeons can modify the technique slightly based on their own preferences, everybody. But if the surgeon in the video would have coated the capsule with the blue Rex dye, it would have looked like this, everybody. I hope you can see it is a better delineation. Yes. Now, after the staining of the dye is complete, we move on to the important step. As we had seen in the video again, CCC. You remember the full form, everybody? Continuous curvilinear capsulorhexis. Continuous curvilinear capsulorhexis. This can be created using either a 26 gauge bent needle, as was visible in the video, or it can be created using a Utrata forceps The forceps you can see in this image, everybody. I hope in this image you can see that the CCC is just getting completed, has just completed, everybody, and there is a forceps like instrument, everybody. It is not the 26 gauge needle. So any of the two instruments, again, what is the use of 26 gauge? What is Utrata? No, nothing specific. It is just the surgeon's preference. Okay, everybody. Now, after we had done the CCC, there has to be main incision creation. If we are talking about theoretical steps, everybody, the main incision needs to be created after the first three steps have been done. But again, in the video, we saw that the surgeon's preference was that the main incision was also created beforehand only. It is just probably to save time. Yes, nothing else. There is no science behind it. Okay. So if we are creating a main incision earlier, there are more chances of leaking from the anterior chamber of the fluid or the viscoelastics used. That is why it is preferred to create it after that. Okay. So the main incision is created as step 4 after capsular axis through a 2.2 keratome. So this is what a keratome looks like, everybody. So it has two edges. You can see this edge and this edge, so that the incision is created equally on both the sides. Now I am saying 2.2 keratome because it must be a 2.2 mm incision. It could have been a 2.8 keratome. So the incision size would have been 2.8 mm. Yes, it could have been a 3.2. That is why, if you remember, we had said the size of incision in phacoemulsification is 2.2 to 3.2. But if we use a smaller keratome, everybody, as in MICS, we can go up to 1.8 mm or even lesser, everybody. So this is the creation of main incision. Now, through the main incision, everybody, we do step 5. So what was the fifth step, everybody? After the main incision, you saw that we did a very important step, and that was hydrodissection. Okay. So what was hydrodissection? That we went underneath the anterior capsule and we injected a jet of fluid. Injection of a jet of fluid to separate, yes, the cortex from the capsule. Now, why is it important to separate the cortex from the capsule, everybody? Again, I hope you have been able to understand the concept. If not, everybody, this is an important step. Then I am drawing a rough diagram for your diagrammatic representation of the same, everybody. This is my cornea. This is my iris. But the pupil is dilated. So let us dilate the pupil. Iris is present only in the periphery. Yes. This is my lens. Capsular axis has already been made. This is my cortex. And in the center is my nucleus. I am taking a syringe and I am injecting a jet of fluid below the anterior capsule to create a plane of separation, everybody. The fluid will travel, hit the equator, then travel in the opposite direction. So this is a plane of separation, so that when I am actually removing the cortex, everybody, in the next step, I don't suck up the posterior capsule. Because as we remember ECCE techniques, we do not want to touch the capsule. We remove the lens except the capsule. So I hope you understand the importance of this step, hydrodissection. Then there is an optional step, step number 6. Optional step which was again not seen in the video we had just seen. This is called as hydrodelineation. Hydrodelineation is again water again, everybody. Yes, so we are again injecting a jet of fluid, but we are trying to separate endonucleus from epinucleus via a jet of fluid. Okay. Again, this depends on the surgeon's preference, everybody. The science behind separating the epinucleus and the endonucleus is that endonucleus is the center part of the nucleus. In nuclear cataract, endonucleus will usually be harder than epinucleus. So if the endonucleus is harder, to emulsify it, we will need more energy, whereas epinucleus is softer, so we need lesser energy. So if we are creating planes, it becomes easier to remove those parts. That's all. Okay. Now, step number 7, everybody. As we saw in the video, fast video was running. What we were doing, everybody? We were doing nuclear fragmentation. Yes, we had divided the nucleus into various parts, and emulsification. With my phacoemulsification probe. Yes. My phacoemulsification probe, how does it work? In the phacoemulsification probe, as I explained, I am explaining again, at the tip there is a piezoelectric crystal. What was the function of this piezoelectric crystal, everybody? It converts ultrasonic waves into mechanical to and fro motion. Okay, so it is like chiseling a stone, everybody. Yes, you are doing this mechanical to and fro motion. Yes, so you are chiseling, and thus you are able to divide the nucleus into smaller pieces to be able to emulsify it and sucked up into your phacoemulsification probe. Yes. After that, everybody, what was the next step in the video? After we had removed the major chunk, yes, we had removed the small cortical pieces, irrigation and aspiration, I and A, yes, for cortical cleanup. Some of the cortical fibers which remain stuck, everybody, we have to suck them out. Irrigation and aspiration, everybody. This can be done through a coaxial instrument as well as a bimanual instrument. In the video, there was a coaxial instrument. Coaxial means there was only one instrument through which fluid was coming, irrigation, and there were ports through which aspiration was occurring. Bimanual means I would have two instruments. One instrument would be irrigating, the other instrument would be aspirating. Again, surgeon's preference, everybody. Yes, I know I'm speaking surgeon's preference a lot, but yes, it is actually that. There are techniques, but there are thousands of instruments, and each surgeon, according to his own preferences, modifies the technique a little bit, everybody. Lastly, we had done implantation of IOL. Yes. So these are the basic 9 steps of our surgery. Please remember them. Please remember the video. There are much more videos to watch on YouTube and everywhere else. If you feel like, watch more videos. But this is a very common thing to be asked in your questions as long question, in your vivas, as well as in your MCQs. So I hope you will be able to comprehend and remember the steps of the phacoemulsification surgery. Now, at the end of this, we have mentioned the word IOL, intraocular lens. So let us now talk about IOLs in detail. IOL, intraocular lens. My first question to all of us, where is an IOL implanted? As we saw in the video, it was being implanted in the bag. Yes, in the capsular bag that was left. But is that the only place? No. Let us see. Again, I will draw a rough cut section. This is my cornea, guys. This is my iris. And this is my capsular bag with the CCC done. Okay, so an opening here. So now I say the IOL can be implanted actually in 3 places. Number 1, okay, it can be implanted in the capsular bag. But I say number 2, it can be implanted here also. What is here? Let's see. And number 3, it can be implanted here. Okay. So let us understand what is 1, 2 and 3. Number 3, everybody. If we see is the space between cornea and iris. So what is the space between cornea and iris, everybody? Anterior chamber. So I will say if I'm implanting the lens in number 3, I am implanting anterior chamber IOL. So I'm writing ACIOL. Okay. But if I'm implanting number 2 or number 1, I'm implanting behind the iris. So behind the iris, it cannot be anterior chamber. It will be PCIOL. Okay. Now, so for PCIOL, basically there are two spaces. The first space, everybody, this is the best site. Yes, this is the usual site we want to implant. As we saw in the video, in the capsular bag. Okay. But what is number 2? What is number 2? Everybody, let's say as a complication, which we will discuss later, we were not able to perform our steps of the surgery very well. So we ended up rupturing the posterior capsule due to either some problem in hydrodissection, some problem in nuclear fragmentation. There can be lots of things. We ended up rupturing the posterior capsule. The posterior capsule was not intact. There was a hole or there was a complete tear. In that case, if I implant the IOL at number 1 in the capsular bag, the IOL is going to fall down into the vitreous. We can't afford that. Yes. So what we say is we need two margins. The anterior margin is the iris. The posterior margin is the anterior capsule. Anterior capsule is, there is a window in the center, yes, but at least in the periphery it is still present. I hope you understand what I'm trying to say. Yes. So I can implant it in number 2 and we call it in the sulcus. So it is not our preferred site of implantation, but if needed, yes, we can implant it here. Okay. So I hope you understand the sites of implantation. I hope you understand that there are two types of IOL, ACIOL and PCIOL. Now, ACIOL is made up of a material which we say PMMA. What is PMMA, guys? I hope you know. Polymethyl methacrylate. Okay. PCIOL can be of two types. A rigid PCIOL, or as we saw in the video, getting implanted through a very small incision, then unfolding, foldable IOL. Okay. Rigid PCIOL is also made up of PMMA. So PMMA, ACIOL and rigid PCIOL. Whereas the foldable PCIOL, guys, can be made up of, the most common material is acrylic, or in very rare cases, obsolete nowadays, silicone. Okay. So acrylic is the material for foldable IOL and PMMA is the material for rigid PCIOL as well as ACIOL, right? Now the question is, sir, what is the difference between ACIOL and PCIOL? Apart from the site of implantation, does the design differ? Yes, it differs. So if an image comes, you need to be able to identify what is a ACIOL and what is a PCIOL. So these are the two photographs in front of you. Okay. The central part, everybody, this is known as the optic part. So this is what is going to give you vision. This has the power, everybody. Yes, center, in the center behind the pupil. This is the part which is called haptic. This is making it fixed inside the capsular bag. Otherwise, it will keep on rotating, everybody. Yes. So this is called haptic. Now, the difference, if you see, is in the design of the haptic. So if we see carefully, I can say this haptic is C-shaped. C-shaped. Yes. This C and this C. Ulta C and Seedha C. Yes. So if we have a C-shaped haptic, that means we are looking at a PCIOL. But if we have an S-shaped haptic, see everybody, this is an S shape, this is an ulta S again. Yes. If we have an S-shaped haptic, that means we are looking at an ACIOL. Okay. So to be able to differentiate between the two IOLs, the only feature is to look at the shape of the haptics. Okay. That's all about the basic IOL design. But apart from the basic IOL design, everybody, we need to know some special IOLs also. So there is something called as the multifocal IOL. Now, just like our spectacles, everybody, the spectacles that we wear in our age, they are monovision spectacles. They are for far vision, usually myopics. But the spectacles that your parents wear, everybody, yes, at the age of 50, when they have myopia as well as presbyopia, so they need a spectacle which gives them far vision as well as near vision. So giving them multi-vision, multifocal, or we call them bifocal. Similarly, we can implant IOLs which are multifocal. So post-surgery, the patient won't need any spectacle, neither for far, neither for distance. Okay, everybody? So it has power for far, intermediate, and near. Okay. Its design is such that there are various rings which you can see on the surface of the IOL. That is how you can identify whether the patient has been implanted an multifocal IOL. Okay, everybody? So this is how a multifocal IOL will look like. Side effect is that it leads to halos, or I can say glare in bright light. I hope you understand why halos are there, because of the design of the rings. Yes. So when light is coming, let's say you're driving at night, light is coming from the front, you will be able to see some discomfort in the form of halos. It is not that you won't be able to drive a car, but there is some sort of discomfort. The second side effect is that there is loss of brightness in scotopic conditions. So scotopic conditions are basically dawn and dusk. Yes. At that point of time, the patient says, I feel better if I switch on the light in the room. We can probably read a newspaper also without switching on the light, even though there is just a little bit of light. But this patient, because of loss of brightness in those kind of conditions, needs to switch on the light to be able to read. But still, multifocal IOLs are very helpful because this patient does not have any dependence on spectacles, right? Another important type of IOL that you need to understand is toric IOL. Toric IOL is used if there is pre-existing astigmatism. So if you have a high cylinder number, basically greater than 1 cylindrical number, then it is preferred to implant toric IOL, so that again we are able to make you spectacle free, at least for far vision. Okay. Lastly, square edged IOL. This decreases chances of a complication which we'll read in a while called as PCO, posterior capsular opacification. Okay. So just certain features of specific IOLs that you need to know, which can be asked to you. Now, before we move on to the complications of cataract surgery, there is a very important part related to cataract surgery that you need to understand. See, we have discussed the steps of the surgery. We know that we need to implant an IOL. But is there a universal IOL that we can be implanted? See, I am emetropic. I don't have any power of spectacle in my eye. So the power of IOL that you will implant in my eye, will it be the same as a patient who is wearing a -2 diopter spherical spectacle? He is wearing a -2 diopter spherical spectacle because his power of eye is abnormal. So if his power of eye is abnormal, that means the IOL that I need to implant should also be of a different power. Yes. So that means if you understand that before doing cataract surgery, one very important part is to be able to determine the IOL power or calculate the IOL power that needs to be implanted. And that is our next very important topic, everybody, calculation of IOL power. So calculation of IOL power, guys, is known as biometry. Okay. So there are 3 steps in biometry to be able to arrive or determine the IOL power. Step 1. In the first step, we measure the corneal curvature. Which investigation is used to measure the corneal curvature, guys? As part of biometry, step 1 is measuring corneal curvature. So which is an investigation? Anybody? Okay, so the answer is keratometry. Please remember that whenever the word kerato is used, we are trying to denote cornea. So kerato is the ophthalmologic language for cornea. Yes. So keratometry, measurement of the corneal curvature. Now, the question which is coming into my mind as a student is, why am I measuring the corneal curvature? We are talking about IOL power determination. What does cornea have to do with that? So please remember that there are powers in two places. One is the cornea and the other is the lens. Yes. So when we are implanting an IOL, we are trying our best to make the patient emmetropic. That's what I tried to explain when we were talking about the types of IOL. Let us try to make the patient spectacle free. So we are trying to adjust the power of the cornea also in the power of the IOL. Let's say your corneal curvature is high. That means your power of the cornea is high. So the IOL implanted will be of a lesser power. The ultimate net result should be zero power. Yes, that is why we calculate the corneal curvature. Curvature means power. Step 2. In step 2, we measure the axial length of eyeball. Axial length of eyeball. So my first question, what is the meaning of axial length? Yes, we all know axial length means anteroposterior diameter. Okay. But we are talking about the axial length of the whole eye. So what is the normal axial length? Anybody can tell me? Normal axial length is, yes, 2.4 centimeter, or I will rather say 24 millimeters. What is the investigation we use to measure the axial length of the eyeball? Yes, it is, you may have read it in your radiology guys also, A-scan ultrasonography. What is A-scan? A-scan, B-scan, M-scan, everybody, I hope you remember. If you don't, A for amplitude. Amplitude scan ultrasonography. Okay. A-scan ultrasonography uses 8 megahertz frequency sound waves. These sound waves are reflected by various structures and we get some peaks like this, everybody. Okay. So when these sound waves are entering the eye, they are striking each structure and they are reflecting the wave back. So we are getting a wave. So if we see this image, everybody, this is my A-scan probe. This is the first point of contact, that is the cornea. So this is the corneal amplitude that I am getting. This is the lens, everybody. The anterior surface of lens, posterior surface of lens. And then this point is your retina. So how do we measure the axial length? Through this, everybody. The distance between the corneal peak and the retina. This gives us the anteroposterior diameter. Okay. So amplitude based calculation of axial length based on ultrasonic waves. Now, we have received two values, one from the keratometry, one from the A-scan ultrasonography. We use both these values in step 3 in particular formulas to be able to get the final value of the IOL. The most commonly used formula is SRKT formula. Okay. But we have to change the formula to Holliday's formula if the axial length becomes greater than 24.5 mm. We use the Hoffer-Q formula if the axial length is less than 22 millimeters. So basically we are saying around the normal, everybody, we can use SRKT. But in extremes, everybody, when the axial length either increases or decreases too much, then there are variations which are bound to occur and they can be solved through different formulas. Also remember that there is a fourth generation formula, Haigis L. All the others, SRKT, Holliday's and Hoffer-Q, they are called as third generation formulas. Not going into the details, guys, not important, right? Haigis L has to be used in post-LASIK cases. See, when LASIK surgery is done for myopia, we change the central corneal curvature, everybody. The rest of the curvature is same. We change the central 3 to 5 mm of the corneal curvature. That creates problems with the calculation of corneal curvature as well as the measurement of the axial length. So you are not reliable. The keratometry readings are basically not reliable. So to offset that, there is a fourth generation formula, Haigis L, which gives us more accurate results. Do we need to know the formulas? In the textbooks that we normally read, SRKT formula is completely written, A is equal to something, something, something. Do we want to remember that? No, we don't want to remember that. Why don't we want to remember that? See, again, I'm talking about the practical clinical stuff. When you go, and if you have ever done a scan or assisted an A scan or at least seen somebody do an A scan, you would have realized that it is completely machine-based investigation. You don't need to even know the formula. You just need to be able to calculate these. The machine itself will calculate, apply all the formulas and give all the values. So we are not going to ask you rudimentary pieces of knowledge which are actually not important, right? So now that we have read everything that there is to read, to know about the cataract surgery, we have seen the videos, we have seen the IOL, we have seen everything, right? So we should talk about something which we don't want to. If there is a surgery, there are bound to be some complications. Yes, we want to avoid them, but then they can occur. So that is what we are going to read in the next 10-15 minutes, complications of cataract surgery here. Right? Now the complications can be divided into three groups. Number one is intraoperative complications that can occur during surgery. Secondly, acute post-operative complications soon after surgery, and then late post-operative complications. We start with our first group of complications, that is operative or intraoperative complications. Now, complete list is given. We'll keep on discussing one by one. The first complication that is written here is posterior capsular rupture. While I was explaining where to implant the IOL, I had already explained this. If we are not careful with our surgery, if some step goes wrong, we may end up rupturing the posterior capsule. And if that is the case, that we need to implant the IOL in a different place, either in the sulcus, that was number 2, or anterior chamber IOL number 3. We understand this. The next complication that is listed here is uveitis glaucoma hyphema syndrome, or in short called as UGH syndrome. Okay. So first of all, everybody, what is the full form of UGH? U for uveitis, G for glaucoma, and H for hyphema. So the first word that we have read here, which is probably new to us, if you are going in the series of the videos, everybody, is hyphema. So what is hyphema? Hyphema is collection of blood in anterior chamber. First of all, we know what is uveitis, inflammation. We know what is glaucoma. Now we know what is hyphema. Now, what is written, everybody? That UGH syndrome occurs due to iris chafing by ACIOL. What do you mean by this? So everybody, let us draw a diagram. It is written by ACIOL. That means in this case, due to some reason, whatsoever that reason may be, the IOL has been implanted in the anterior chamber. Yes? If you understand, this is a complication by ACIOL. That means whatsoever the reason may be, but an ACIOL, anterior chamber IOL, has been implanted in this patient. Now, what is the problem due to ACIOL, everybody? See, ACIOL is resting over what? ACIOL is resting over the iris. Now, iris is a muscle between which there is a center pupil. So, the iris is a movable structure. Yes or no? It will keep on dilating, constricting, dilating, constricting. Now understand, this is my IOL, which is a fixed structure kind of. It cannot move. And this is my iris, which is moving. So what is occurring, everybody? The iris, due to its movement, continuous movement, is rubbing against the IOL. Yes? So the iris is rubbing, and that is iris chafing by ACIOL. Iris is a part of uvea. When you are rubbing the iris, everybody, it will get inflamed, uveitis. Yes? Iris is a pigmented tissue. So due to the pigmentation, by rubbing of iris, pigments will be released. The pigments will go and block the trabecular meshwork and will cause glaucoma. Iris is a vascular tissue. So when the iris is rubbing, one of the vessels may rupture and when the vessels will rupture, you will see that the blood will collect in the anterior chamber, and that will be hyphema. So everything is occurring due to one thing, the fact that iris is rubbing against the anterior chamber IOL. I hope you understand UGH syndrome. Okay, moving on everybody. The third complication is written as vitreous loss. It is the most serious. Again, this actually occurs due to PCR. If there is PCR, the vitreous can come from the posterior segment into the anterior segment. It can leak and it can cause a complication. Next complication is expulsive choroidal hemorrhage. From the name, it is making itself clear that hemorrhage is occurring in the choroidal blood vessels. Question is, why does it occur? It occurs due to sudden IOP changes. What do you mean by this? If the surgeon is not careful, everybody, there can be IOP fluctuations. The IOP can go as high as up to 60 to 70, then it can go suddenly as low as up to 10 to 15. Whenever the IOP is going high, it is compressing all the blood vessels. Whenever the IOP is coming down again, it is relaxing all the blood vessels. So if there is a sudden decompression and compression, everybody, it was 70, then it like this, 15, then again 70, then 15. So due to this kind of movement, when there is sudden compression and then sudden decompression, the blood vessels may rupture. Choroidal blood vessels may rupture and lead to choroidal hemorrhage. Why is the word expulsive written? Because choroid has large vessels. When there is choroidal hemorrhage, the gush of fluid or the blood is so much that it pushes all the structures outside the eye. Okay? Now, bleeding from choroidal artery, obviously. So the question that they are asking is, what is the source of this hemorrhage? Source of this hemorrhage is choroidal artery. But what is choroidal artery? All of us know through the blood supply, I hope, that the choroid is supplied by short posterior ciliary artery. So the source of hemorrhage in this case will be short posterior ciliary artery. I hope you understand why does it occur, how does it occur, and the questions that can be asked on it. Moving further, everybody. It is written damage to superior rectus while passing the bridal suture. So this, everybody, has nothing to do with phacoemulsification. Bridal suture or bridal suture, everybody, this is a suture which is passed below the superior rectus muscle in SICS and ECCE to stabilize the eyeball and get a better surgical view. If you have to make the incision in SICS in the sclera, so you need greater sclera to show everybody, yes? So you pass a suture below the superior rectus and then pull that suture so that the eyeball moves down, everybody, and a greater portion of the superior sclera is visible to you. So that is what it means, everybody, that there can be damage to superior rectus if the suture is not passed correctly. Specific to SICS and ECCE, not to phacoemulsification. Lastly, everybody, it is written as Descemet's membrane detachment. Let us see what is Descemet's membrane detachment. Let's understand. I am writing DMD, Descemet's membrane detachment. Okay, everybody. Again, if you understand the steps of the surgery, it becomes easy for you to understand this. This is my cut section. I am doing a surgery. I have an instrument in my hand like we saw in the video, everybody. This instrument is supposed to be pointed slightly down posteriorly. While I am taking the instrument in or I am taking the instrument out, if by mistake, everybody, this instrument becomes like this, okay, like this. So what I will do, I will damage the cornea from the inside. It can lead to Descemet's membrane detachment. My Descemet's membrane will hang like this. So if my Descemet's membrane gets detached, everybody, there can be an opacity which forms there, everybody. Because if the Descemet's membrane is detached, the endothelium is also hanging down, yes? So for this, what is the solution? We inject an air bubble. This air bubble will push everybody, the Descemet's membrane, up, and slowly it will reattach if you are lucky. Yes. So Descemet's membrane detachment, what is the treatment? Descemetectomy. Okay, desmetopexy. So basically we are reattaching the desmoid membrane by the help of an air bubble, and that is what is written here. Reattached by injecting air bubble or gas in anterior chamber, known as desmetopexy. Okay, so I hope you understand the complications. All these are intraoperative complications. They can be avoided by being careful in the surgery, though there are some cases where howsoever may you try, you are not able to avoid. But I hope you understand and you learn about this. The important complications that can be asked as questions is UGH syndrome, expulsive choroidal hemorrhage. Done? Now that we are done with intraoperative complications, let's move on to the second segment, everybody, and that is acute postoperative complications. Acute postoperative complications, as it is written, we take a timeline of 3 weeks. Complications which occur within 3 weeks after surgery. Now, the first complication is self-explanatory, iris prolapse. The incisions that we have made, the side ports and the main, if we have not closed them properly, due to the IOP inside the eye, the iris will come out, iris prolapse. Nothing to explain here. Second is a very important complication that we will read in detail, endophthalmitis, everybody. That is a dangerous word for every surgeon, every cataract surgeon to hear, and that is what we are going to understand in detail, everybody. So let's understand in detail the complication that is endophthalmitis. Okay, it's a topic in itself. Endophthalmitis. What is the name suggesting you? The name can be divided into 3 parts for me. Endophthalmitis. So itis is telling you it is some kind of inflammation. Ophthal means inflammation in the eye, and end is trying to denote the severity of the inflammation. That means whatever this complication is, whatever this inflammation is so severe that it can completely destroy your eye or you may lose vision, end of the eye. Yes? So, how do I define it? It is an inflammation, but which type of inflammation? That is where I start my definition. Suppurative inflammation of all layers of the eyeball except sclera. So there are 2 important words in this definition. There is inflammation, but what kind of inflammation? Suppurative inflammation. It is affecting all the layers of the eyeball. Only exception is the sclera. So the simplest question is, in endophthalmitis, all of the following parts of the eye are affected except the answer is sclera. The second question which you need to remember is it is suppurative inflammation. So as soon as I hear the word suppurative, I know that the condition is infective. So if it is an infective condition, everybody, that means there are microorganisms responsible. So most commons come into effect. Yes. So let's see the most commons or the etiology of endophthalmitis. The etiology of the endophthalmitis I can discuss in 2 groups. Acute post-operative endophthalmitis or late onset post-operative endophthalmitis. Okay, I hope I'm very clear about these 2 parts. Acute post-operative is within 7 days after surgery. Late post-operative is 6 weeks to 6 months after surgery. So the onset has to be 6 weeks to 6 months, somewhere during that duration the onset, and that is when we denote late onset. Now, what are the bacteria, everybody? In acute post-operative case, we have our favorite group of bacteria. Whenever we don't know anything, we answer one bacteria, and that is Staphylococcus aureus. Yes, but here it is not aureus. That's the only difference. It is Staphylococcus epidermidis. Now I'm presuming if you're watching ophthalmology, then you have read microbiology, you have passed your second year, second prof, guys. So can you tell me, can you rake up your brain and tell me Staphylococcus epidermidis, what is the other name? What is the grouping of the Staphylococcus here? What is the other name we use? Yes, very good. CONS. Coagulase negative staphylococci. Yes, coagulase negative staphylococci. Or yes, is coagulase positive. What about late onset cases? In late onset cases, we say that the most common bacteria is Propionibacterium acnes. Propionibacterium acnes. Right, guys? Now, we know the etiology. So, what are the presenting or what is the presentation or what are the presenting clinical features here? Now, focus on the word itis. It is inflammation. If there is inflammation, there will be severe pain. Obviously, there will be severe pain. If there is inflammation, there will be redness. Yes or no? And if the whole eye is getting affected, there is bound to be loss of vision. Can I say? So this will be the basic presentation. The patient will say, I have severe pain, redness, and obviously the patient will say, even after cataract surgery, I am not able to see anything, right? When I will examine the patient, what are the findings I will be able to see? I see, first of all, that the conjunctiva is red. So the redness is a symptom, and the same symptom becomes congestion or hyperemia as a sign. Okay, so I'm saying there will be congestion or hyperemia. Then I see the cornea. I see the cornea is also hazy due to inflammation, corneal haze. Then I see the anterior chamber. It is an infective condition. So I see that there is this dangerous word. I hope a lot of us know this word already. If we don't, does it sound similar to the word we have just read? Hyphema, hypopeon, hyphema, hypopeon. Hyphema was collection of blood. Here, think about it. Infection. Infection means collection of pus. Collection of pus in anterior chamber. Okay. So, this is what will be seen in the anterior segment. Now we are saying again all the layers of the eyeball are affected except sclera. So anterior segment is affected, but posterior segment should also be affected. That means if we look at the vitreous will also show some abnormality. So we say there is vitritis. How do we know it is vitritis? We see some yellowish exudates in vitreous. There is inflammation, there is infection. Exudates will be seen, yellowish exudates. Vitreous, which is normally a transparent gel-like structure, will develop yellowish exudates or opacities in it. So based on the symptoms, the history of the surgery, plus our findings of anterior segment involved, as well as posterior segment involved, we know that we are talking about a case of endophthalmitis. Okay. So let me show you a photograph. If such a photograph comes into your exam, along with the history that a patient has had a history of cataract surgery, let's say 3 days back. Okay, and you get this photograph. What do you see, everybody? You see this redness, so you know it is congestion. You see that the cornea is not clear, hazy cornea. More importantly, you see a very important stuff here. You see this. You see collection of pus in the anterior chamber. Along with the history given in the question, I think this should be enough to diagnose it as endophthalmitis. I hope I'm pretty clear about this image and the understanding of endophthalmitis. Now that we know what is endophthalmitis, how it will occur, how it will present, everybody, what is the important point here? That we need to save the eye. That means treatment becomes very important for me. But treatment depends on one word for me. Treatment depends on the word vision. When a patient with endophthalmitis is coming to you, or any patient, you are recording the vision. Now there can be two sets of patient. One patient who has spent 3-4 days thinking it will get normal and then come to you 3-4 days after that. That means the endophthalmitis is already developed, and possibly the endophthalmitis has already made the patient blind. Okay. Now, what is blindness? We had read the definition: blindness is vision less than 3/60 in the better eye with best corrected vision. But that is not what I'm talking about. Leave that to PSM. We are talking about blindness, clinical blindness here, everybody. When do I, an ophthalmologist, say that a patient is blind? I say a patient is blind when there is no perception of light. I hope all of you have taken vision of patients in your postings. If not, everybody, please go to the optics video. There is a video explaining how to take vision, what are the stages. First we use Snellen's chart, then we use finger counting, then hand movement, then torchlight, everybody. I hope you know that. If not, please do see that. So if the patient cannot even perceive light, that means he can't even say whether there is some light in front of him, that is when we say that the patient is blind. Now the question that comes into my mind, if the patient is blind, everybody, does the eye have any use? No. It has infection, it may spread. So what do I want to do? I want to do a surgical treatment to remove the eye. And what is that surgical treatment known as? Evisceration. Eviscerate. Viscera. Remove the viscera. Eviscerate. If you want me to define evisceration, it should be very easy. Remember the definition of endophthalmitis. All the layers are inflamed except sclera. So here I will say I will remove all the eyeball except sclera. Okay. So removal of all structures of eyeball except sclera. Okay. I hope we are clear about this evisceration. But if the patient presented to us timely, that means the vision was still present. Howsoever little, howsoever more, doesn't matter, but the vision is still there. The patient can count fingers, or patient maybe can read something even on Snellen's chart. I will try to save the eye. I know it is an infection. If it is an infection, everybody, what will I try to do? I will try to give antibiotics. Yes, I will try to give antibiotics. But I know through my common sense that the infection is affecting both the anterior as well as the posterior segment. So through my chapter anatomy, routes of ocular drug administration, I know that for the posterior segment, the route of drug administration has to be intravitreal. But for the anterior segment, it has to be, yes, topical. Very good. So that means I will give antibiotics at two places, topically as well as intravitreally. Intravitreally, the antibiotics that we gave are vancomycin. The dosage is 1 milligram in 0.1 ml, or the dosage rather, plus ceftazidime. Ceftazidime is 2.25 milligram in 0.1 ml. Obviously, we have to culture the vitreous exudates. We have to find out the exact cause and then probably tailor our treatment. But before we are waiting for that, the treatment in every case, bacterial endophthalmitis, has to be vancomycin plus ceftazidime. Okay. Topically, we give broad spectrum antibiotics. Along with that, what we have to do? We have to remove the vitreous. Pars plana vitrectomy. Vitreous is a gel. It is providing a nidus for the microorganisms to grow. So we are going in through the pars plana, everybody. We are cutting the vitreous and removing it. Pars plana vitrectomy. Okay, everybody. Decreasing the microorganism load, the infection load, the bacterial load. Okay. And that's the treatment to save the eye. Please remember, it is a local infection. There is no need of systemic antibiotics. I hope we are pretty clear about this. That's all about the very important complication, endophthalmitis. Moving on, guys. Other complications in the acute post-operative period can be uveitis, self-explanatory, everybody, inflammation of uvea, retained lens matter. So if the irrigation and aspiration, which we do to clean up the cortical matter, that has not been done properly, there can be some retained cortical matter which can cause inflammation. So we have to give high dose systemic steroids to be able to suppress that, everybody. There can be hyphema if during the surgery iris had been touched a lot, everybody. So there can be some leakage post. Astigmatism if toric lenses have not been implanted. So all this is basically understood, self-understood. What is important for us to discuss here just a little is TAS, toxic anterior segment shock syndrome. Okay, everybody. So TAS, toxic anterior segment shock syndrome. This is a sterile inflammatory reaction. See, why is it important? Because this is also presenting like endophthalmitis with inflammation. But the important point is endophthalmitis is infective, whereas it is sterile. So it is a sterile inflammatory reaction to toxic products. What can be a toxic agent? Something on the IUL, something in the viscoelastic. Okay. So if the manufacturing process is not very good, if there is some kind of sterile contamination, the powder on your gloves goes inside, something like that, anything like that, but it is sterile, everybody. And it is easily treated with corticosteroids. As soon as you give corticosteroids, everybody, the inflammation will be resolved. That is basically the difference between endophthalmitis and TAS. The main word is sterile. Also remember, everybody, a very important complication that I am writing, flat or shallow anterior chamber. Now, what do you mean by this? Post-surgery, there is some leaking from the wounds. Yes, wound leak. Or there is ciliary choroidal detachment. If there is detachment, then everything will come anteriorly, everybody. Pupillary block glaucoma or malignant glaucoma. So when you read glaucoma, you will understand pupillary block and malignant glaucoma are almost always the same thing. So these are the important causes of a flat or shallow anterior chamber. Done? Now, moving on to the last part, everybody, and completing our complications, the late post-operative complications, which occur after 1 month, but it can occur after 1 year or 2-3 years also. The most common, the most important complication that we need to study here is PCO, posterior capsular opacification. Let me write, this is the most common late complication of cataract surgery. Okay, let us study it in a little detail, guys. PCO, also known as secondary cataract, also known as after cataract. Okay, now PCO, posterior capsular opacification, we are giving two other names, secondary cataract or after cataract. Now, is it a type of cataract? That's the question. I am saying secondary cataract or after cataract. But understand, we are not reading cataract. We are reading a complication of cataract. So basically, we say these are misnomers. The actual problem is posterior capsular opacification. So now understand, why are they misnomers? So if we remember, in ECCE techniques, we don't remove the posterior capsule. We have implanted an IOL here and we have not removed the posterior capsule. If our irrigation and aspiration is not complete, if we have left some material, everybody, it migrates and it forms a plaque on the posterior surface. Okay. Now this plaque on the posterior surface is also an opacity. So it gives the appearance as if it is a cataract. It behaves like a cataract, and that is why the misnomer secondary cataract, cataract has occurred again, or after cataract, after removal of cataract, again cataract has occurred. But please, again and again, I am saying these are misnomers. Okay, everybody? Now, most common late complication. This occurs 6 to 10 weeks after surgery. That is the usual onset, everybody. Okay? Now, what does it cause? It causes gradual, painless loss of vision. Okay. What is the treatment? The treatment is ND YAG. That is the difference now here, everybody. It is not ND glass, ND YAG. ND-YAG laser posterior capsulotomy or capsulotomy. See, basically, if there is an opacity, I need to remove it. Now, there are basic two ways of removing it. I do an open surgery. I do all the steps of like the cataract surgery, give an incision, everything, then go inside and then finally remove the posterior capsule. But if I remove the posterior capsule, you can see the IOL will fall down. So I can't do that. So that means open surgery is not the answer. So what I'm doing is I'm doing a safer option. I'm doing a laser-based surgery. So the laser is fired, and just like we had done CCC, basically we are creating a small hole in the center of the posterior capsule. Something like this. Yes. So that the peripheral support still remains and there is a hole in the center through which light is able to travel. Yes, guys. The laser used is ND-YAG. Now, what is the wavelength of ND-YAG laser? The wavelength of ND-YAG laser is 1064 nanometers. What is the mechanism of action? Again, think about the three words: burn, break, or coagulate. What am I doing to the posterior capsule? Am I coagulating it? Am I burning it? Or am I creating a hole by breaking it? Yes, the answer is the same: photo disruption. Okay, guys, I hope we are clear about the treatment part. Yes. Now, lastly, PCO. There are two types of PCO. Let's see the photograph and let's try to understand through that. Two types of PCO. The first type, everybody, is known as Elschnig pearls. And the second type is known as Sommering's ring. Okay. Now, if you see this image and I tell you these two names, what is the answer going to be? Is it more likely to be a Sommering's ring or a Elschnig pearl? I hope you can see pearl-like deposits all over the posterior surface, and thus this image is of Elschnig pearls. Yes, Sommering's rings is calcified deposits, and this is pearl-like vacuolated appearance on the posterior capsule. What is most common? 90% of the cases almost present as Elschnig pearls. I hope we are clear about the most common late complication, that is posterior capsular opacification. It is not a type of cataract. Please remember this. Okay. Going back up, everybody. We have done the PCO. Then everybody, very important complication which is written here is Irwin-Gass syndrome. We will read this in retina also, everybody. Irwin-Gass syndrome is cystoid macular edema plus bullous keratopathy plus vitreous touch. So the macula is getting edematous. There is keratopathy in the cornea. The cornea is also getting edematous, everybody. Then there can be displacement of IOL. The name itself is very clear. The IOL which we implanted, it is not remaining in the center. It is going up or down. So let's see, everybody. Sunset syndrome. Sunset means it must be going down, looking like the sun is setting. Inferior subluxation. Sunrise syndrome, it is going up, everybody. Superior subluxation. Or lost lens syndrome, that from the pupillary area there is no lens visible. The lens has either gone posteriorly into the vitreous. There was PCR, you could not detect it and it has fallen down, or it has gone up or down too much, everybody. No part of it is visible in the pupillary area. Now, the next complication, everybody, is anterior capsular phimosis. Anterior capsule, everybody, the margin of which you had left, the periphery of which you had left, that becomes fibrosed. It contracts, everybody, and thus displaces the IOL a little. Okay, I'll show you a photograph. This doesn't occur very commonly, but whenever it occurs, it looks like this. I hope you can see here, everybody. I will mark with blue color. This is the CCC which had been created. And now you can see all around the margin there has been fibrosis, which is leading to contraction, and thus it will displace the IOL due to forces which are getting applied on the capsular ring, everybody. Yes, I hope we are able to understand the important complications. If you want to sum it up, everybody, there are 4 or 5 important things that you want to remember. The first important thing, the foremost important thing that you want to remember is endophthalmitis. Then secondly, posterior capsular opacification. Then thirdly, you want to remember UGH syndrome. These are the 3 important things. Apart from that, one single line, I have told you about all the important complications, and that is all that I can teach you as part of cataract surgery, starting from the names of the surgeries to the technique to the IOLs and ending up with the complications. I hope you have been able to understand. I hope if you have any doubt, you try to solve it, you see the video again, or you ask us. Right, guys?